Hello, everyone. Happy Thursday. Welcome to another VMR. Excited to hang out with you all today, and especially to hang out with Ethan, who I'm sharing the stage with. This is his first case discussion. I think his ratio of case presentation to discussion is probably the most skewed. I really don't think you need to know any more about Ethan based on the fact that he's been a CP Solvers team member for a few months now, but has been actually part of the community for much, much longer, presenting case after case after case. Um, and I admire Ethan a lot. I don't think he knows just how much because I see a lot of me in him. I was absolutely obsessed with clinical medicine as much as he seems to be, um, and excited to see his passion and mine collide, and even more so in the very narrow space of the CP Solvers discussion, virtual discussion space. So Ethan, welcome. I'm super, super excited to co-discuss with you. I'm curious, how are you feeling?
Yeah, a little bit nervous and excited to learn about the case today. Yeah,
Yeah.
so I think I know CP Source about 1 year ago, and since then, my passion for clinical reasoning has really been inspired by all of you. Yeah, so really grateful to be a part of this community and excited to learn today. Yeah.
Gratitude is a two-way street, my friend. In the ascribing role, we have Patricia. I'll hand the mic to you, Patricia, just to say hello.
Hi everyone, I'm Patricia and I am IMG from Cameroon and I'm really happy to scribing for you today.
Thank you, Patricia. And a last minute save from Mariana, who's doing the teaching points. I don't know, Mariana, are you in a place to say a quick hello before we introduce our case presenter?
Yes, hello everyone. I'm Mariana. I'll be doing teaching points today. I'm very excited for this case.
Thank you, Mariana. Last but not least, I want to welcome our case presenter, Manahil. Hello.
Hello, everyone. So, I am Minahil. I am an international medical graduate from the Pakistan. I have been the part of VMR since January, and this will be my second case, and I will be presenting more cases very soon. And I am very much excited for presenting case my today to the Rabih.
Oh, thank you so much, Manahil. It's so nice of you. Where in Pakistan are you located? Or are you
And I'm from Islamabad.
from Islamabad? I've been there
Yeah.
many, many times. As you may know, I grew up in Pakistan. I grew up in Lahore, actually, 15 years there. So if you ever need to gossip about the VMR community in Urdu, we can talk about most people at their backs anytime, anytime.
Yeah.
Where are you now? Are you still in Islamabad, or are you doing it away or experience somewhere else?
I am currently in Michigan for my observerships.
Oh, awesome. How long have you been in Michigan?
I come last month on
Last
29th.
on the 29th.
Yeah.
And are you applying this year, or when is your application intent?
Yeah, I am like planning to apply this year if I am able to complete my rotations.
I see. Understood. Understood. Well, wish you best of luck. Excited to get to know you better through your case today. So,
Thank you.
yeah, Patricia, feel free to share the screen whenever you're ready, and we'll jump right in.
So, mm, this is a story of 82-year-old male who presented to emergency department with a fever and difficulty breathing. So the patient was brought by his son. His symptoms began 3 days ago, starting with a fever of 102. He took paracetamol at home, which provided a temporary relief, but the fever spiked again and fluctuates between 100 and 102. So, along with the fever, he experienced throat pain and shivering. He reported a decrease in the oral intake due to throat pain, also developed productive cough, with blood in sputum occasionally showing frank blood, and his shortness of breath became noticeable at the rest and worse at night, particularly when he lay down. Additionally, the patient mentioned having intermittent nosebleeds over the past 2 to 3 months.
Oh, very intriguing start, Manal. Thank you so much. So maybe Ethan, I can summarize the information and then ask you just where you're going. But it sounds like we're faced with a patient who has fever and difficulty breathing. But as Manahil explains the background and the timeline, she mentioned to us that the fever started a week ago and that he was having upper airway symptoms, a sore throat, but also that he has hemoptysis, is coughing up blood. And curiously enough, she also mentions that he had epistaxis for 2 to 3 months beforehand. So I'm really curious, where are you inclined to begin your thinking? What is your mind doing to start?
Yeah, so first of all, we have a relative old patient. So I would be very curious to know about his past medical history because the background could change our framework a lot. And generally, in a patient with fever and difficulty breathing, I'll focus more on the shortness of breath here because it usually links to the cardiovascular systems. And then with the symptoms of hemoptysis, the localization here seems to be the airways. And with fevers, I'll tend to think about infections and combine with the time course here. And then, but we'll have to think about what infections are linked to hemoptysis, and because that's not a usual presentation in common diagnosis like community-acquired bacterial pneumonias or like viral pneumonias like caused by influenzas or SARS-CoV like nowadays. So I would also get his meds because some patients with anticoagulants would be more prone to bleedings, and I'll get other more better framework of his review of system, and then take the next step. Yeah.
Rabih, you are
Are
muted.
muted.
Oh, shoot. Oh, thank you so much, Mariana. Sorry, I didn't realize that. Sorry. I was just talking to myself, apparently, and Nar. I was saying, Ethan, that I completely agree with you. I think your analysis to zero in on the hemoptysis and the shortness of breath is spot on. And just to explain how unusual this situation is, the vast majority of patients with hemoptysis do not have shortness of breath. And the vast majority of patients with shortness of breath do not have hemoptysis. So whenever you have the combination of hemoptysis and shortness of breath, you know that you are in a very specific situation. So most hemoptysis is from irritation of the airways from bronchitis and is benign. Whenever hemoptysis is accompanied by shortness of breath, you know you have an alveolar or vascular problem, i.e. the hemoptysis is deep. So Ethan, if we think very simplistically, and this is where I'll ask you to think alongside me. If we think that hemoptysis is from the alveolus, based on the fact that the patient is short of breath, we know that there's a connection between the alveolus and the blood vessel. The only way that blood makes it up is if there is a connection between the alveolus and the blood vessel. And a very helpful way of thinking about where the problem is to ask yourself, did the problem originate in the alveolus and then erode into the blood vessel? Or did the problem begin in the blood vessel and erode into the alveolus? So to help us analyze that question, what do you think are the most common causes of hemoptysis that feature shortness of breath? Like what have you seen of hemoptysis and dyspnea?
You mean the most common cause of hemoptysis and shortness of breath?
Yes.
Yeah, I think most commonly acute bronchitis by viral infections, and then other causes like TB infections or fungal infections. Yeah.
100%. Exactly right. So the one adjustment I would make is most patients with viral bronchitis do not have shortness of breath. That's because their irritation is from the airways, which is insufficient to cause them to be dyspneic. They might wheeze, but they should not, they have enough reserve in their airways to ventilate just fine. So whenever you're dealing with hemoptysis and dyspnea, you know you're deep in the lungs. You're well beyond the airways. You're in the alveolus. And so, as you just said, chronic inflammatory parenchymal diseases are by far and away the most common cause. So what you might expect to see is a mass like lung cancer or a cavity like TB or fungal infection. And I think that's really, really important to emphasize that your instinct was to say that the most common reason why somebody has hemoptysis and shortness of breath, i.e., a connection between the alveolus and the blood vessel, the problem begins in the alveolus, in the lung parenchyma, and then erodes into a blood vessel, like a mass or a cavity, and that's why the patient bleeds. Fair? Are we on the same page?
Yeah.
Awesome. So here's the interesting twist, Ethan. What does the presence of epistaxis do to your calculus of prioritizing a pulmonary parenchymal problem? What do you think?
Yeah, so the fact he had epistaxis means probably makes me made me think that he is more prone to bleedings. So either he is having some, like, for example, taking anticoagulants or having a bleeding tendencies, or the underlying diseases also are affecting the nasal cavities. Yeah.
Exactly right. So either this patient has a space-occupying process involving their alveoli that also exists in their upper airway, or the patient has a diffuse vascular process. So this aliquot is incredibly rich. And to highlight how much progress you make, I'll summarize and see what questions you have left. Most people with hemoptysis don't have dyspnea. Most people with dyspnea don't have hemoptysis. The presence of the dyspnea and hemoptysis localizes the lesion to a lesion causing fistulization or connection between the alveoli, all the way, the alveoli and the blood vessel. Okay? Vast majority of people, as you said, when they have this, have a problem that begins in the alveolus, like a mass or a cavity, that erodes into the blood vessel. However, if there is a hint of a blood vessel issue in a distant organ, you then have to reprioritize and wonder if the patient actually has the origin of the problem in their blood vessels. So here, before we heard the epistaxis, the probability of a space-occupying alveolar process was through the roof. But the moment Manahil sprinkled in the fact that he is bleeding in his nose from blood vessels, probably makes us reassess that calculus. He could be, as you said, bleeding from his nose, not because of blood vessels, but because he has a space-occupying process in his nose as well. But the tension is there. Lungs say space-occupying process, the nose says vessel. Which one will win? We'll have to see. But you would not entertain vascular problems this early on if it weren't for the epistaxis. Awesome. Any questions left around that analysis, Ethan?
Yeah, great. I think, yeah, because of the epistaxis, we rely more to vascular problems now. Yeah, but we will see what the case unfolds. Yeah.
There's a trap here that I wanted to leave you with. And the trap here would be that he doesn't actually have a pulmonary or vascular problem. So since you understood all of that, I'll ask you to think out loud. Is there a scenario where you can imagine that the patient has no problems in his lungs? What do you think?
No problem with lungs. So not a pulmonary problems, and then not a vascular problems as well.
How can a patient with epistaxis, dyspnea, and hemoptysis not have a pulmonary problem?
And like, for example, a diffuse alveolar hemorrhage or something like that.
That's a
No.
problem. That's a lung problem, isn't it?
Oh yeah.
he swallows his blood. So he's having epistaxis. And the only reason that he's having cough and shortness of breath is not because his lungs are affected, is because he has aspiration of his blood into his lungs. And while his lungs are secondarily affected, the problem may just be severe epistaxis. And I've seen that a few times where somebody says, oh, I'm coughing, but actually it's really just here. So really good close examination of the posterior oropharynx to evaluate for dripping blood is going to be really, really important here. So false hemoptysis or pseudo hemoptysis is really important to entertain here. The reason that that's less likely is most patients with epistaxis do not have fever. And so it would be very, very unusual to have an isolated febrile epistaxis problem without the fever coming from somewhere else. But that's really important to make sure that the lung problem is actually a lung problem rather than a referred problem from the nose. All right, Manahil, you're off to a very, very interesting start. What do you have next for us?
So awesome discussion. So for the second aliquot, his past medical history include hypertension for the 4 years and chronic obstructive pulmonary disease for 10 years. He also have ischemic heart disease with triple vessel coronary artery disease, and he underwent 3 percutaneous coronary intervention, and his last PCI was complicated due to branch occlusion. He also have benign prostatic hyperplasia and chronic kidney disease secondary to renal cyst, and patient was non-compliant with his medications. He smoked 3 packs per day for 15 years, but quit the smoking 10 years ago, and he is addicted to moist snuff. He didn't choose illicit drugs or consume alcohol. He don't have any recent travel history, no known allergies, no significant family history. The patient did not go for the regular checkups and his vaccinations were not up to date, but recently someone in his household had tuberculosis.
Oh my gosh, wow. Wow, this is very, very intriguing. Can I ask, just because of the TB exposure and the TB exposure, is this case from your rotations here in the US or is this case from your time in Pakistan?
It's from my Pakistan during my internship.
And that's very, very helpful. As you can imagine, like a TB exposure in US is much less likely than in Pakistan. You mentioned something I just want to clarify because I missed it. You mentioned that he had ongoing use of after tobacco, you said he was using something regularly. What was he using?
Maybe you know it's known as Naswar here in Pakistan, the
Yes.
moist snuff.
Yeah, gotcha. Okay. I'm not sure what diseases that's associated with, so that I'll have to look up. But we certainly have a very, very rich history here, Ethan. I'm curious, what did you make of this background?
Yeah, so obviously the most profound history here is the recent TB exposures. So first of all, management-wise, probably he have to be isolated in a negative pressure room for precautions. And then there's a lot of a rich past medical history here for hypertensions, COPDs and CADs. So one thing I would like to say is that probably based in cardiovascular and pulmonary system is probably not too good. So he's prone to be born dyspneic. And then with the CAD, he's probably taking the APTs and antiplatelets, so this makes him more prone to bleeding as well. And yeah, so oh no, I think a COPD exacerbations or a ADHF could precipitate shortness of breath here, and congestive heart failure itself could cause hemoptysis because of the congestions of the lung, but probably not a very common presentation. But I think the center of gravity here is the TB, and I would love to get a sputum and get an acid fast stain of his sputum very quick. Yeah.
I completely agree with you. I think that is a superb analysis. The heaviest thing we heard about is his TB exposure. And I think that since you brought that up very early, we have to worry about that. I love that you mentioned the idea that patients with coronary artery disease can get decompensated heart failure, and by venous congestion. The venous congestion can then cause the pulmonary capillaries to have bland hemorrhage. And that bland hemorrhage is certainly more likely in patients who take dual antiplatelet therapy. It's never a good thing when patients are unable to take their medications. But in this case, it might be a good thing because since he's not taking his medications, I think the concern about antiplatelet medications would not be something very heavy right now. I love that. What do you think, Ethan, what do you think the value of your exam will be? What are you going to be looking for on his exam before you even jump to do it?
His breathing sounds because of pneumonia concerns, and then CV exam for JVDs and hepatocellular jugular reflex for assessment of his heart. Yeah.
Agreed. I think the most powerful exam finding will be if he has overt decompensated heart failure. That tends to be the easiest way to get to the bottom of hemoptysis, is when you see evidence of decompensated heart failure. I also think that if you find focality on your lung exam, say the right lung or the left lung is affected disproportionately, that can help you prepare for the worst case scenario. The worst case scenario is on your watch, the patient develops massive hemoptysis. And so if you already have a sense of which lung is the bleeding lung, you would probably then ask the patient to be put in a position with that lung down. And the idea being, if that lung is down and bleeding, at least the blood will not shoot into the other lung, causing worsening problems. If you put the bleeding lung up on this and put the patient lying on their side, then what could happen is the blood could drip via gravity to the other side of the lung, causing worsening problems. So I'd say a heart failure exam, and then knowing which lung is more affected is very, very helpful. And I'm really curious to see if his nose has any lesion, any specific lesions, because if we represent this as a febrile pulmonary problem, then I think that'll be a very, very narrow analysis. But if this is a febrile pulmonary and upper respiratory problem, then our calculus will shift tremendously. So getting a sense of what his nose is like, I think, given his chief concern of his associated concern of epistaxis, is going to be illuminating too. Awesome. All right, why don't we get that next to aliquot, Manaho?
So, in next in initial assessment, his vital signs were like his BP was 110/70, he was hypertensive, his temperature was 101, heart rate was 85, respiratory rate 28 breaths per minute, and oxygen saturation of 88% on room air. When I went to see this patient, like he was lying in the bed, he was very pale, sweating profusely. His breathing was labored and he seemed in distress. And he also seemed malnourished, his sunken cheeks with a frail build. Despite his overall weakened state, his mucous membrane was still moist. And his throat was congested with moderate erythema. There was no lymphadenopathy. His GVP was normal. His skin was pale. There were no rashes or lesions. On respiratory examination, we found fine inspiratory crackles at the lung base that was more pronounced on the right side. There was decreased air entry bilaterally. And other than that, like his chest was, appearance was normal, and also the palpation exam was normal. Rest of his exam was unremarkable. There were no murmurs, no pedal edema, and his TCS was 15 out of 15. So before I give you guys lab findings, I want to show the EKG of this patient. So I will be sharing my screen. I think that I cannot share my screen. I'm not a co-host.
Now you are. Yeah, you should be able to do that now, Manan.
Is my screen visible now?
Yes, it looks great. All right, Ethan, it's my favorite thing to do, to read EKGs with people, because often they're perceived as being so intimidating, but let's fight that battle together today. So what do you think?
Yeah, so when looking at a EKG, I first look at its rate. So about 70 to 80, I think. And then I will look at the QRS interval to see if it's narrow or wide. So it's narrow here. And then I see to see if it's regular or irregular. And then I think it's regular with the P waves seems to be the same, although the quality of the EKG is probably the patient shivering or something. Yeah. And then I look for axis to see if there's left or right axis deviation. I think here the axis is normal. And then I look for ST segments and T wave changes in continuous leads. And I think there is no, and I think there seems to be ST elevations in the cordial leads in V1, in V2, V up and V4, V5, V6, a little bit elevated. The other leads, yeah. And then, yeah, that's probably all I can have now.
Absolutely superb, masterful read of this EKG. I agree with you. This is sinus rhythm. I see a tall P wave. I'm not sure if it meets criteria for right atrial enlargement because of the wandering baseline, but whenever the P wave is really tall, that suggests right atrial enlargement. I also see a P mitrale, which is a very long P wave. You can see, especially in V1, just how long and biphasic that P wave is. Very, very suggestive of left atrial enlargement. So this is biatrial enlargement. The other thing that you see is, as you pointed out, there's very alarming ST segment elevations in V2 and V3, especially so. And so the question is, what is the significance of ST segment elevation? And you cannot analyze ST segment elevations without commenting on the QRS, because depolarization abnormalities in the QRS, depolarization, cause repolarization abnormalities. And so here, if you look closely at V1, you have the bunny ears morphology of an RSR prime. That morphology is diagnostic of a right bundle branch block. And so even though the QRS appears narrow, I think it actually is almost 3 boxes wide. So it's a wide-ish QRS. And so whenever you have a wide QRS, you'll notice that the ST segments can be deflected in the opposite direction of the amplitude of the QRS. So you'll see a predominantly negative QRS in V2 and V3. And that QRS has a deflection of the ST segment in the opposite direction. And so that ST segment may actually be normal for this QRS and as expected for this specific QRS. However, I would say that because there is no prominent R wave until V5, I would worry a little bit that this patient has poor R wave progression. So I think we already know this patient has coronary artery disease, and so we can easily attribute the poor artery progression to prior MI. The active question right now is, do these ST segments represent an expected finding in the context of the QRS problem, or do they reflect new ischemia? And I think the pretest probability of ischemia here is not high. The reason for that is that the patient is presenting with a febrile hemoptysis syndrome rather than crushing substernal chest pain. But I think you have to factor in the patient's pretest probability also being influenced by the fact that they have underlying coronary disease, and importantly, recognizing that this patient has not been in care and may not have trust or healthy relationships with healthcare professionals. And so you always have to wonder, what is the quality of the history that I'm getting here? You have to wonder, you don't know that. So I think a prior ECG would be helpful, but I imagine it's not available because the patient hasn't been in care for a long time. So all that you can really do right now is to get a troponin and to watch this abnormality evolve. If this patient presented with crushing substernal chest pain with this EKG, I would probably call cardiology right away. But since his presentation is weeks old, or at least days old, you have time to figure this out. And a repeat EKG and a troponin would be helpful. I think it's really important not to get distracted from all the pretest hypotheses we had about pulmonary diseases. So this has the risk of us forgetting that we need to take a very close look at his lungs and distracting us. So this is very, very important. Now we have two main problems: a febrile hemoptysis syndrome and this EKG abnormality. This EKG abnormality could represent ischemia, but it may actually be just a benign finding in the context of the QRS morphology. At the same time, while we talk about benign and extreme serious ST elevations, ischemia, Ethan, can you think of potentially some other causes of a chronic ST segment elevation?
Yeah, for example, LV aneurysms. Yeah.
Exactly right. Yeah, I think if we had a repeat EKG and they were normal, I think we would probably put it on the QRS. But another possibility, if their prior EKG showed ST segment elevations, is the idea that he might have an apical infarct with an LV aneurysm. And I think it's hard to ask how that LV aneurysm is relevant to a pulmonary syndrome, but if we conjecture and wonder if he has an RV aneurysm as a result of a prior infarct, then all of a sudden the stasis, thrombus, and dislodgement into the lungs may become relevant. So I think those are those are important thoughts to have. Any questions about any of that or the EKG?
Yeah, I think the RSR is probably, and the presence of our BBB is probably kind of relevant here, as you point out the possibilities of possible RV aneurysms and PE for that could explain the hemoptysis. Yeah, but otherwise, I think pretty good now.
Awesome. Thank you so much, Manal. Maybe we can go back and analyze the exam, Ethan. I think we heard that the patient was hypoxemic, tachypnic. Oh, sorry, Manal, did you have more EKGs, or I'll see what you
No.
want to.
Like, I want to just give the official interpretation
Yeah,
of this,
yeah.
like what is, yeah, like you guys dissected it beautifully. So I have highlighted some points over here too. So like you can say like biphasic P wave in the lead V1 and nodal P wave in the lead 2. So it is suggesting bilateral atrial hypertrophy. And like we have borderline ventricular hypertrophy that is indicated by the sum of S wave depth in lead V2 and R wave height in lead V6 that is like 35 mm. So it is indicating bilateral ventricular hypertrophy. And also the R wave in the V2 is suggesting the ischemia because it's transitioning from positive to a negative deflection.
Yeah, I think you are muted again.
That's my theme today. Interesting. Thank you for that read, Niall. I really appreciate it. All right. Maybe we can analyze the exam, Ethan. What did you think of the exam?
Yeah, so the patient is hypoxemic, probably not that uncommon since he has COPD already. And then, although he has no JVD, but we all know that JVD examination is not perfect. And then the fact that he has bivascular crackles that I think could indicate pulmonary edema, the possibility of acute decompensated heart failure is not ruled out completely. And then there's a right side more than crackles more than left side, and that could indicate a focal lung lesions as well. So a chest X-ray and possibly other chest imaging would be important. Yeah.
I completely agree with you. I think that we really have to clarify the severity of this case has really gone very high. And we had a patient who was coming in with a few days of symptoms, which often means that you have some time to diagnose it, but you see those vital signs. The patient's very ill, tachypnic, hypoxemic, febrile, and has this EKG with a question of ischemia. So all of a sudden you really need to get to the bottom of this very quickly. And my biggest advice is to actually remember the value of pulmonary imaging and what an X-ray is really helpful for. And we use the abbreviation CXR to remind us to order X-rays, and those letters are exactly the number of things that a chest X-ray is really good for. It can help diagnose pulmonary edema, it can help diagnose community-acquired pneumonia, and it can help diagnose a pneumothorax. And in this patient, the pretest probability of either of those things is not through the roof. Patient is not a classic decompensated heart failure patient. The patient is not a classic community-acquired pneumonia patient. And the patient is not a pneumothorax patient. So the probability of an X-ray being super revealing here is pretty low. And so if the resources were available, this is somebody who would probably get a CT scan very quickly. With contrast, to both look for parenchymal issues, but to pacify those blood vessels that we've been talking about so much. So yeah, I'm very, very worried about this patient. I think we only have a few hours or maybe even minutes if he opens up to get to the bottom of what's going on. So very, very high amplitude, urgent situation with probably serial EKGs, a troponin, a CT scan with contrast, and an echo would be the things in resource heavy scenarios. But we'll see how this case evolved. Very intrigued, Manahel. What do you have next?
Okay, so coming towards the lab findings, his hemoglobin level is of 11.1, hematocrit 34%, WBC is at 11, platelets at 274. His ESR was 68 and CRP 190. His electrolytes were normal, but RFTs showed elevated creatinine at 3.3. Like we don't have his baseline creatinine, like he was not have frequent visits, so his creatinine at this time was 3.3. His BUN was 13. Coming towards the cardiac enzymes, like they are almost within the normal limit. His troponin was 0.03 and CK was 97. LDH was 331. AST was 22. CKMB was 27. His echo revealed an ejection fraction of 35%. But like when the patient had the PCI last time, his EF was 45%, which has been significantly decreased this time. Other than that, the patients have like elevated phosphorus of 6.8. His magnesium was 1.5. Calcium was 8.7. His PTH was 171. In liver enzymes, his AST was 35. ALT was 48. Alkaline phosphate was 130. Albumin was 3.6. And we also did his AFP stain that was negative. Shall I stop here or move further towards the imaging?
Oh, we can stop here briefly. I think, Manahal, I think you're presenting this case so masterfully. Every aliquot is getting me on the edge of my seat. I'm so excited to talk about it that I forget to hit the mute button half the time. Ethan, what did you make of these labs? What stuck out to you?
Yeah, so the hemoglobin is slightly decreased, but generally reassuring since he's presenting with a bleeding syndromes. And then the white count is not super elevated, but mildly elevated. And combined with the ESR and CRP, I think it could just indicate a underlying inflammatory syndromes, either in infections or a malignancy possibly. And then although he had CKD, so, the creatinine of 3.3, although we don't have the baseline here, so we don't know if it's just indicative of his CKD or is there a acute renal injury involving in this patient. Yeah, other labs, I think the high phosphorus indicated of the renal impairment, and then the liver function is normal. And then the elevated LDH always bugs me since we already seen several cases in VMR that has only signal with elevated LDH and turned out to be a malignancy. I'm always concerning about that and would like to trend that. And yeah, I think the game changer would be a CT chest. So yeah.
Absolutely superb analysis. I think you're more than ready to be an intern. This is just such a nuanced take of everything. And so I don't have anything to reflect with you, but I will just take a moment to summarize and inventory all the organs we're dealing with. So we have kidney, we have heart, we have lung, and then we have upper airway are the four things we're tracking. Surrounding all those four things is the presence of very overt inflammation by fever, white count, ESR, CRP. So the organs we're tracking, we're circling them under a systemic inflammatory syndrome. Here is the problem. The problem is every organ, except the upper airway, has chronic disease in it. The lungs have COPD, the heart has ischemia, and the kidney has CKD. And so we're having a very hard time figuring out which organ has acuity. We got a scary EKG, but the biomarkers are negative and the syndrome is low. So in my mind, I'm putting the heart abnormalities lower and lower and lower. The lung abnormality, even though the patient has chronic disease in his lung, the presence of hemoptysis is incompatible with COPD diagnosis alone. So investing very strongly in the lung is very high because the abnormalities we find, i.e. hemoptysis and fever, don't map on to a diagnosis of COPD, unlike the EKG abnormalities, which map on very well to a chronic cardiac issue. And so here we have the tension with what to do with the kidney, because we don't know the baseline creatinine. And if the patient's PTH is very high, it means this a significant component of his kidney dysfunction is chronic enough for his PTH to compensate. But I think the value of a urinalysis here to tell us if his presentation right now is compatible with CKD or not will be very helpful. Because while proteinuria can be a common consequence of CKD, hematuria would not be. So we have bleeding nose, we have bleeding lungs, and the question is, do we have a bleeding kidney? And I think if we have a bleeding kidney, this case gets a lot of momentum. If we have a non-bleeding kidney, then I think the creatinine becomes less and less significant and maybe just pre-renal in the context of the hectic inflammatory syndrome. So I'm really fading the heart right now. The lungs are screaming, as you said, a CTA. The nose is interesting history, but we haven't seen it bleed now, so it may be irrelevant. You know, we're just going on history. We haven't seen any marker to map that onto. So the nose may fade or may come back. The lungs are heavy, and I think that the power of a UA in this case will be through the roof. And if there's no hematuria, the kidneys are probably gone. If there is, gosh, we got to run. Any questions or any other thoughts that cross your mind, Ethan?
How do you interpret the LDH?
Yeah. I think the LDH is a very, very helpful test in many situations to be able to sniff something out when there is no other clue. But if you had an elevated LDH and the patient had a hemolytic anemia, the LDH doesn't tell you anything more. And so here, the context of this LDH is a very coalescing syndrome. And so since that syndrome is coalescing, I probably would park that and see what the LDH has to offer after I understand the syndrome. And so if you have an anemia and an LDH, as an example, you probably can't analyze the LDH until you know the anemia. And if the anemia is hemolytic, you're done. And if the anemia is from malignancy, you're done. So right now, it's hard to analyze the LDH without knowing what you're trying to map it onto. And so I would really want to know what's the nose, what's the lung, what's the kidney. And if it turns out that this syndrome is actually a heart failure syndrome with renal infarct, and now, okay, now I know where the LDH is coming from. Or if it turns out that this is a diffuse pulmonary problem with the CT scan lighting up, then I would say, oh, maybe the LDH is from the lungs. So I think there's more data to be needed to understand the syndrome better, to find out where the LDH attaches. If it were over 1,000, I think that's when no matter what the syndrome is, it grabs your attention. But here it's low grade enough that I think we'll be able to attach it onto something that we hear about shortly. All right, Manahil, tell us more.
So amazing discussion. So moving towards the imaging, abdominal ultrasound showed mild bilateral pleural effusion, enlarged heart with mild pericardial effusion, bilateral renal cyst with grade 2 and 3 renal parenchymal changes, and prostate enlargement. Initially, we started the patient like it looks in the fluid overload, so we discontinued the fluid and administered 60 mg of Lasix diet, followed by the 40 mg of Lasix. And we also started the patient on the antibiotics like 400 milligram of moxifloxacin in BD. But like we initially thought that his heart failure symptoms may be precipitated due to the lower respiratory tract infection, and it will improve with these antibiotics and all. But like his dyspnea still persisted despite of this, and his creatinine increases from 3.3 to 6.1. And like to rule out the underlying cause of the dyspnea, we perform an HRCT, and I can show the images of the HRCT, and then later I will give you guys the findings.
So Ethan, you're gonna interpret EKGs and CTs today. This is for your first discussion. I think that's quite a task, but okay.
I don't have this, the video I have in this line illuminator image.
Oh, no worries at all. So Ethan, what do you see?
Yeah, so first of all, the chest X-ray, obviously heart is big and seems to have bilateral blunting of the CP angles and prominent pulmonary vessels, probably indicative of pulmonary edema or other things, but no obvious pneumonia patch, I would say.
Yeah.
And then for the CT chest, left pleural effusions, and yeah, this is not in lung window, but
Yeah.
other than that, probably pericardial effusions as well.
Yeah.
And then
Excellent.
much I could
Yeah.
see.
Yeah, you're in the mediastinal window right now, I assume, and you see a left-sided pleural effusion. And then the image that you were looking on is, I think, maybe the scout film for the CT, which looks very much like an X-ray. But yeah, right now we don't have the lung window, so we'll wait to see if Manahil has that. But yes, I think the patient has a large, moderate to large left-sided pleural effusion. He also has some aortic calcifications and a small pericardial effusion. I can't quite appreciate very much a large one. Do you have any other images, Manahil?
Yeah, I have another one. So this is the second.
All righty. So there's your lung window. Ethan, what do you think?
Yeah, okay. So it seems to in the lower lobes, right lower lobes, there seems to be emphysemas and some consolidations, I think, in the right lower lobes.
Yeah, very abnormal CT scan, right? Like you see a large amount of emphysematous changes, especially on the right side. You do see an alveolar opacity.
Yeah.
And now the question for you is, are you able to define the underlying lung parenchyma? Are you able to see the lung underneath it? Or is the lung completely hidden in those abnormalities? What do you think?
I don't think it's completely hidden.
Yeah, I agree. The fact that you can make out the lung is suggestive more of a ground glass opacity rather than a frank consolidation. And so the way you can tell is if you just look at most things, you can make out the underlying lung architecture. So I think as Manahil's exam suggested, there's right greater than left ground glass opacities. The idea of ground glass is you can still see through the underlying, you can see the glass, but you can see through it. I'm also intrigued. I'm not very good at reading nodules on a CT scan, but let me try to direct you to where I thought I saw a couple of nodules that were peribronchovascular, I think. So if you look at the, you know what, it's hard for me to be confident, so I don't want to direct you to something wrong. But I agree with you. I think there's a large left-sided pleural effusion. There's diffuse right greater than left ground glass opacities, and I think there might be some nodules, but my confidence around reading nodules is very poor. So maybe we can hear what the official read was, Manahil, and then hear Ethan's analysis.
Yeah, so like it like helps us a lot for the diagnosis, but I will not give that now. So other than that, the HRCT shows septal thickening in the interlobular region. There were reticulation, subpleural cyst with a honeycomb appearance, subtly ground glass haze, and atelectasis.
Fascinating. All right, we'll go back to the whiteboard and yeah, maybe once Patricia shares her screen, we can. Yeah, I think one mistake that I made, Ethan, was I assumed all those cystic lesions were emphysematous changes, but I think on reflection and after Manahil said it, they do look a lot like honeycombing because of their clustering and their relatively small size. So yeah, what do you think of this CT finding?
Yeah, so seems to be there's a focal process that affects the right lower lungs more than the left lung. So that could be indicative of a chronic infections, I think. For like TB or other fungal infection, I think.
Yeah.
And how we can make progress, I think would be maybe a bronchoscopy to get some like to get some ball. And yeah, other than that, my knowledge in this is probably not good.
Yeah, I think you can make some progress by asking yourself, honeycombing, do you associate with that with an acute finding or a chronic finding? What do you think?
Chronic findings, for example, like IPF or
Exactly. Exactly right. So, when you have honeycombing, this is a chronic disease. And the disease evocative of it is idiopathic pulmonary fibrosis. The strong argument against idiopathic pulmonary fibrosis alone is that most IPF will not have ground glass opacities unless the patient is presenting with a flare from an infection. So whenever you see ground glass opacities in the context of honeycombing, you have to wonder, wait, is this an IPF mimic, or is this actually different? Is this IPF with a flare? But let me ask you this. Remember where we started, Ethan? We started with this person is having hemoptysis. And so you got the CT scan for hemoptysis. What do you think? Why do you think the patient is having hemoptysis?
Yeah, very good question.
Thank you very much.
It could indicative of the ground glass.
Yeah. There you
The
go.
ground glass opacities.
Let me ask you a better question.
Yeah.
Hemoptysis, alveola, or vessel? You got the CT scan. Do you think this is an alveolar problem or a vessel problem?
Yeah, alveolar problem.
I understand why you're saying that, but explain why. Why did you say alveolus?
Yeah, because ground glass opacity represents like a feeling of something, materials in the alveoli.
And what do you think that material is if the patient's having hemoptysis?
Blood.
Yeah. Where do you think that blood came from?
The vessels.
Yes. Remember, primary alveolar problems are very obvious. What were your examples? Lung cancer, cavitary lesion, bronchiectasis. The patient is having hemoptysis, and you see no primary alveolar problem. So the presence of ground glass opacities in the context of hemoptysis, especially if the hemoptysis has been appreciable, is very concerning for alveolar hemorrhage. The finding of diffuse ground glass opacities in a patient with hemoptysis is very, very underwhelming for an primary alveolar problem, and very, very concerning for a diffuse vascular problem. And so the question is, what does the additional finding of honeycombing mean? It might raise the specter of a chronic inflammatory problem that has caused devastation in the lung parenchyma and is now taking off and causing vascular hemorrhage. So I think what you said about the bronchoscopy is very, very important, because bronchoscopy, as we learned on Monday, is a test with a relatively low yield in all populations. But it is very, very good at helping you decide if this is actually a diffuse alveolar hemorrhage and has a role to play in this. The other thing that will be very important is, again, are the kidneys bleeding or not? But many of the vasculitides that we might be thinking of in this patient also leave the lung parenchyma scarred. As an example, many patients with microscopic polyangiitis, or MPA, often have an IPF-like pattern on their CT scan. And so let's remember that vasculitides cause vessel problems, but some of them also cause extravascular signatures. So I agree with you. I think a bronchoscopy might be very illuminating in this patient. but the urinalysis remains something I think very important. And if a bronchoscopy is not available, if the UA shows bleeding, you may be able to diagnose a pulmonary renal syndrome. And if the UA shows bleeding, you might be faced with the practical question of, this patient's pretty sick. In addition to antibiotics, should we give stress dose steroids? And I think you're getting very, very close to saying the risks of not giving steroids are getting higher and higher and higher as the creatinine skyrockets, as the lungs get worse. So from the context of hemoptysis, the finding of diffuse GGOs is very, very suggestive of diffuse alveolar hemorrhage. But let's see what Manahala has in store, because I know we're already out of time thanks to her incredible case.
Okay, so like moving to the next delegate, he reported significant efforts for the breathing, and like his episodes of epistaxis and hemoptysis reoccurred, and we ordered an autoimmune panel. So his CNK, GBM antibodies, and anti-dsDNA were all normal, but his P-NK level was elevated with 61. His histone IgG was also elevated with 38.9. And his anti-nucleosome and IgG was also elevated 15.4. So the clinical presentation, HRCT finding, and positive P-NK confirmed the diagnosis of granulomatosis with polyangiitis. But like before we could initiate any diagnosis, his creatinine level deteriorated. Like we discontinue the Lasix, but it still deteriorates, and we transfer him from the cardiac department to the nephro department. And like this was a patient who touched my heart a lot, and like despite his departmental relocation, I remained personally invested in monitoring his progress. His creatinine level like shows some improvement after the hemodialysis, but like the burden of his disease, fibrotic lung, make it very much challenging for him to breathe and maintain the adequate oxygen saturation. And unfortunately, this complications ultimately contributed to his passing.
No, I'm so sorry to hear that, Manal. I can see that I can see just how in-depthly involved you were in this patient and in your emotions right now, and I'm very sorry for his loss. It just goes to show you how devastating this disease is, and I'm really, really glad that you are sharing his story, because I think we're all the wiser for it, and I think everyone will be much more prepared to diagnose this condition sooner next time. I just want to make sure that we do as much justice as we can to the patient by trying to be as precise as we can with the diagnosis. So, Manahel, was his P-NK was positive? Is that right?
Yeah, his P-NK was 61. Like normal range is till 10.
Yeah.
So it was 61.
And did you happen to know what his MPO status is? Myeloperoxidase, or is that not available?
No, it's not available.
Gotcha. So a C-NK is a imperfect way of targeting a specific serology, which is the antiproteinase 3, PR3. The P-NK aligns much more with the presence of MPO or myeloperoxidase. While most patients with GPA or granulomatosis with polyangiitis have PR3 positivity, I'm told about 5 or 10% have P-NK. So this could be a rare scenario where a patient with granulomatosis with polyangiitis, GPA, has a positive MPO or P-NK, but that's pretty rare. My instinct would be that this patient actually has microscopic polyangiitis, because the P-NK is more in keeping with the MPO antibody, which is characteristic of microscopic polyangiitis. And I say that also because the high-resolution CT findings of IPF-like appearance and honeycombing is very well described in microscopic polyangiitis. The classic extravascular manifestations of granulomatosis with polyangiitis on high-resolution CT include nodules and cavitations. So here, both the serology, P-NK, and the high-resolution CT findings are more in keeping with microscopic polyangiitis. Why is that distinction important? I'm not sure. It's well beyond my pay grade. I would imagine that it might have implications for the nuances of prognosis and the nuances of immunosuppression. But I'm curious, Manahil, what thoughts do you have on, did you have any other thoughts on what I just said, or what were the conclusions that you all came with to go with GPA over another ANCA-associated vasculitis?
Like when we get HRCT, that was mainly showing the fibrotic lung disease, and we have the suspicion of this in the back. That's why we conducted this panel to confirm the diagnosis.
Yeah, I agree. I completely agree with you. I think the probability of ANCA-related vasculitis is very high. I would guess that it's probably microscopic polyangiitis based on p-ANCA and high-resolution CT findings. But at the end of the day, I'm learning from Carl that it doesn't really matter, that the treatment is the same. So ultimately, I think a devastating set of conditions that can show you how important it is to suspect them quickly and diagnose them quickly. Manahil, I'm curious, what did you learn from seeing this patient and putting this case together?
Yeah, there was a lot of learning from this case, and I think I learned a lot more. That was like patient with a disease not always present in a typical way, especially if a patient have many comorbids. So we, like in this case, patient have multiple comorbids and overlapping symptoms, and like we need an integrated approach in this case. And detailed assessment, history, presentation, all of these things are needed for the definitive diagnosis and treatment of the patient.
Yeah, absolutely amazing. I think you really presented it in such an extremely helpful way. I think what stood out to me was how you were overtly mentioning the TB exposure and the tension that lived with. And also, I think you painted a really powerful picture of how chronically ill this person was with his physical exam to show us that this was actually a chronic disease, not an acute one. And it was very, very tantalizing to see how you told us what you did. You thought this was heart failure and pneumonia, very common, and that you didn't skip over the fact that failure to respond to treatment is a very powerful clue that the patient doesn't have the condition you thought. It was very, very well presented. Thank you. I just have one more question for you because I can't help it. Did you happen to have a urinalysis, maybe from your memory? Did he have any evidence of hematuria or anything like that, or do you not remember?
I think like we conducted, but that was not significant.
I see. Interesting. Okay. Thank you so much, Manahil. Ethan, what did you think? How was your experience?
Yeah, thank you so much, Manahil, for presenting this amazing case. And yeah, I think it's such an educational case. And my most impressive part is the link of HRCT and the hemoptysis to like link the blood in alveoli to the GGO pretty fast. And even without a UA here, and then you can link the main problem to be the vascular problems. I think that's very impressive. Yeah, thank you so much. Really fun. Yeah, this is really fun.
What was more impressive is watching you tackle a case of this complexity and share your thinking with so much grace and accuracy and actually humility, which was absolutely awesome. Really enjoyed doing this with you. And I hope I get to do it many, many more times, Ethan. That was a lot of fun. Alrighty, last but not least, Mariana, please take us home.
Thank you all for this amazing presentation and discussion. I'll try to be brief here, but we had a lot of teaching points in this case. So we started with a patient that is 82 years old. So for elderly patients, past medical history is very important to know what we are dealing with. And the patient also had fever, so we started to think, could we be dealing with an infection here? And then we found out that the patient had hemoptysis with shortness of breath, and this combination is very unusual. And because it is unusual, we can think in a very particular way. So for hemoptysis, we could have an alveolar or a vascular problem. The shortness of breath point towards an alveolar problem, but there is necessarily a connection between the alveoli and the blood vessel in order to cause the hemoptysis. So we could be dealing with chronic parenchymal inflammatory disease, and we start to think about mass versus cavity at this point. And then we start to think how we could connect the epistaxis in this context. So we could have a space occupying lesion that is also present in the nose because it's a distant organ. So we have to think about the blood vessel as the origin of the problem. The patient had exposure to TB, so this rings a bell for a possible cavity causing the hemoptysis. And because the past medical history of chronic arterial disease, we can think about a decompensated heart failure causing alveoli congestion, and we try to connect the alveoli congestion could connect with the blood vessel and cause the hemoptysis. So it's very important to look for heart failure exacerbation signs in the physical exam for this patient. Further, we had the ECG that could represent acute ischemia, but because patient had no previous ECG to compare, it's difficult to say if it's a acute problem or a chronic problem. And at this time, lung issue couldn't be ruled out. We also thought that if in this previous episode of CAD, a patient had like a right ventricle aneurysm causing stasis and a thrombus, the patient could have a pulmonary embolism. So at this point, we were considering if we were dealing with a heart problem versus a febrile hemoptysis syndrome. And then we discussed something that is very important, that is when the chest X-ray is helpful, we have to remember it's only for pulmonary edema, CAP, and pneumothorax. So if our differential diagnosis do not include these etiologies, we have to think about another exam that could be more helpful for us. And at some point, we had an upper airway, lung, heart, and kidney problems. So we started to think about systemic inflammatory disease. But a problem that we found out is that in this patient, every organ that we were tackling had also chronic disease. So the patient had COPD, CAD, a probable CKD. So at this moment, we were trying to find out which organ had the acute problem or all of them. So this was an issue that we found out, especially because the patient didn't have like a healthcare for a long time. So for the kidneys, we had increased creatinine with increased phosphorus. So maybe we could have just a chronic abnormality, but it was very important still to rule out if we had an acute problem with the kidney. So it would be very important for us to have an UA to know if the kidney was also bleeding as the lung and the upper airway were. With the chest CT, we were able to find a honeycombing pattern, and this points out to a chronic disease, maybe idiopathic pulmonary fibrosis or an IPF mimic versus IPF with a flare due to infection. So we also noted GGO in the context of hemoptysis is a sign of DAH, so we started to think about MPA. And vasculitis could explain the scenario because it could be causing the DAH and also the epistaxis. So it would be very important for us to assess the kidneys because if the kidneys were bleeding, we could indeed have a vasculitis here. And the final diagnosis ended up being a vasculitis granulomatosis with polyangiitis versus microscopic polyangiitis. Thank you very much for this amazing case.
Oh my gosh, Mariana, I think you ran out of breath at the end because of all the amazing teaching points you were able to recap. That was amazing. You literally latched on to everything. That was so cool. Thank you for articulating it, and appreciate you jumping in last minute to do this. All right, guys. I hope you have a great rest of your day, and look forward to seeing you next time. Bye.